I was really keen to be here today because I think these meetings are really useful when we get to know each other and exchange ideas. And sometimes I think we don't even know what everybody's doing in the university. So I find these really, really useful. And as Maria also alluded to, these initiatives through the Jean Golding Institute or the EBI are extremely, extremely useful. So thank you for organizing. As Shervan said, I'm a biomedical engineer. I work in the medical school. I've been doing research in congenital heart disease for 15 years now, first at Great Ormond Street and then at Bristol. And I've worked in different techniques, both experimental and computational. And what I wanted to share today is examples of work that we've done using a technique called statistical shape modeling that can lend itself to, especially as you will see in one of the examples, some machine learning applications. And so far, what I will show is the potential of it in some small studies. We have a lot of data. We will hear about biobanks, for instance, in one of the talks, and we have a lot of data in the hospital here in Bristol. And so the potential for running much larger studies, I think, is there. So what is statistical shape modeling? It is what it says. It's a technique, so if we break it down, that looks at populations. It allows us to some inference. We're looking at across the population of shapes. So that's the second word. Essentially, it's a technique that allows us to look at morphology, which is, in my opinion, especially important in congenital heart disease. And we look at all kinds of geometrical effects in a population. This is not just medical. It can be used for any kind of shape, but it has been developed for 2D and, more importantly for me, 3D applications in medicine. And modeling means that we apply some kind of mathematical simplification to describe this variability in shapes. So that's essentially what it is. Why I find it particularly useful is that it allows us not just to describe shape, so it's not just qualitative, although it has a lot of 3D information, which is really useful. It also is quantitative. Some of the quantitative morphological work that I did before knowing about SSM involved 2D measurements from medical imaging, which are fine, but often lack some of the complex information that can be really useful to unravel the morphology of both heart and vessels in these patients, both before and especially after surgery, as some of these patients may undergo multiple surgeries, and therefore their morphology is really complex. So not only we can describe, we can look at differences in patients, patient groups. It allows us to look at the mean configuration of a shape, and I'll show you an example, and how far every patient is from that mean configuration. And we can interrogate that. But also it can use I use the word loosely, but predictive way. So we can look at relationships, as I will show you in the next slide. The method outputs both a mean shape, but also variations around the shape as numbers. So these are called shape vectors. So we can use them to run regression analysis and other analysis that allow us to, for example, classify patients or identify relationships between changes in shape and clinical variables. Just one slide on the methodology. From a morphological point of view, this technique is really appealing because it doesn't require landmarking. The way in which it works is that it produces an atlas. What we mean by that, and just some words that I may use in describing the case studies. So the method outputs a mean of a population. So here we have several aortic arches. It calculates a mean 3D aortic arch. That's called a template. It also calculates how far each individual patient is from that mean. And these are called shape deformations or shape modes. The ensemble of all of them, we call it an atlas, in that case for an aortic arch in patient with a certain congenital heart defect. And so that's effectively how it works mathematically. We focus especially on the template and on the deformations, and we can work it back to each individual patient. So what I thought I would do today very quickly is go through 3 examples. I will not go in detail, but hopefully it will give you a sense of how we can apply it, and I will show you 3 different applications. The first one is what I call a cross-sectional use of statistical shape modeling. So we take a population and we interrogate shape. In this case, it started from discussing with clinicians. We were discussing other work around 2 congenital heart diseases, bicuspid aortic valve and aortic coarctation. And somebody said, I've noticed in my clinical practice that the left ventricle in patients with aortic coarctation tend to be rounder. It was as simple as that. Can we study that? And we said, yes, we can with this method. So we did analysis to look at the shape of the left ventricle in patients that had aortic coarctation, which is a congenital heart disease. We started, and we start always from medical imaging data, routinely acquired, anonymized, and in particularly in this case, we use what's called a short axis sat sequence from the MRI. We reconstruct that, and image reconstruction is actually one of the fields where AI can be really, really useful, although here we do it manually in a small population. We create a shape of left ventricles from different patients, and then we apply our statistical shape modeling, looking also at not just variability within the population, but also correlations with some clinical variables. We also complement this with some more traditional morphological measurements because we wanted to see, it's useful to understand what some of the shape modes represent because sometimes they're not intuitive. And so we calculated some indices like sphericity, and tortuosity of the ventricle and the aorta. We had a population of 110 patients with aortic coarctation and or bicuspid aortic valve and some controls. And I'll gloss on the clinical data in the interest of time. But what I want to show you is that what we can calculate is the average configuration of the left ventricle. This is the mean of all 110 patients, but we can also calculate templates for each of the subgroups. And so even qualitatively, which is the first step of the analysis, we can see that as hypothesized by that clinician based on her observations in clinic, the isolated coarctation patient had a rounder shape of that ventricle. It's really clear even from the qualitative analysis. But we can take this forward. And what's interesting in this application that I'm showing as the first example is that we can first unravel the meaning of some of the shape modes because some are quite small variations depending on the shape that we're looking at. And for example, here on the left, you have 2 graphs showing mode 3 and mode 4 that correlate with sphericity and conicity. So we kind of explain a bit what these modes mean. More interestingly, on the right, we have modes that correlate with clinical data. So here we also calculated from the MRI global longitudinal strain, which is a functional parameter for the heart, for the left ventricle. And we showed that these variations in modes correlated with better or worse global longitudinal strain. So what it suggests is that there is a functional implication of these changes in shape. The second example that I want to show is what I call longitudinal statistical shape modeling. And the name kind of speaks for itself. So this is a feasibility study, and I should have said for the previous as well, both these 2 papers are work from a PhD student and then fellow that worked with us, Frozo Sophocleus. What Frozo did in this study, her PhD was about bicuspid aortic valve, so the previous paper fit in terms of the left ventricle, and here she looked at the shape of the aorta. Patients with bicuspid aortic valve tend to have what's called aortopathy, so dilation in their ascending aorta. And what we can do with this application of statistical shape modeling, it's not quote unquote just look at the shape of the aorta and the mean configuration, but by having a longitudinal design whereby we have at least 2 shapes per patient, we can mathematically retain that association between patients and develop some kind of longitudinal registration whereby essentially we capture changes in shape, not just mean shape. And that in congenital heart disease is really useful in my opinion because we can look at growth and remodeling. So the way in which it works is that we have different individuals that have multiple input shapes at different moments in time, and we feed all of that into our algorithm. And what we get is the evolution of the mean evolution of shape in time The program also converts age into what is called a disease age. So it's the evolution over time, correlating kind of the difference between the different time points. And what we can see is, what we also did in this study was also some kind of, I use again the word loosely, validation to show that the patient at different time points from the real MRI data of the patients matched with the shapes derived from the model, so the computed deformations. This was just a feasibility study, so we did it on 41 patients with 94 shapes, all derived from MRI. And what we get is, again, deformations, but this time is the change in shape that we're capturing. And what I think it's really useful, though in this example makes no sense clinically, but it's shown as the potential of the technique, is that because we have these variables around time, so disease onset and disease acceleration, we can interrogate who develops a condition or phenomenon like dilatation earlier and who progresses faster. And here, for example, purely for argument's sake, we compared men and women. We don't have a sufficient population to do anything of clinical meaning, but what we can show is that if we have subgroups of interest, we can identify groups that develop the, let's say, dilatation earlier and that dilate faster. And the third example is unsupervised clustering, so more of a machine learning problem combined with statistical shape modeling. So this is work from another PhD student of ours, Youssef Al-Jassam. And here, as a case study, we look at aortic valve replacement. Without spending too much time here, but again, it's just to give you a flavor of what we've done and the potential. We have a small population of patients that have had different types of aortic valve replacements, including procedures like the Ross procedure or the Zaki procedures and valve sparing. We have data sets of preoperative shapes and postoperative shapes. What we can do here is the traditional SSM, quote unquote, so looking at deformations. And what we define as the shape of interest also is up to us. So here, for instance, we ran kind of two parallel studies looking at only the aortic root and ascending aorta, which is effectively where the surgery takes place in this patient, or the whole aortic arch, just to run kind of a richer analysis, and looking at all the different deformations that I already discussed before. But if we take this a bit further to look at can we classify and potentially identify new clusters of patients of interest, we can run more traditional methods like principal component analysis, for example, looking at correlations between mode 1 and mode 2 in the analysis. But also we can apply unsupervised clustering. And here it becomes really interesting because we can identify these different clusters. Here, for example, we could interrogate them based on the type of surgery that they had, although the population was too small again, it was more a feasibility study to see how we could apply it to this three-dimensional problem. But the technique works. Nothing stood out from, for example, an obvious question would be, would patients with the same surgery cluster together? Maybe that was too simplistic as a question to ask, so I will not spend too much time analyzing the results from that point of view. But in terms of the potential, we can then also compare clusters. So we can select at which point we look in our endogram and then identify variables of interest. They can be, in this case, morphological, like tortuosity or different sizes, and say, are patients, for example, in the different clusters, do they differ because of, let's say, the tortuosity of the aortic arch post-surgery? And yes, we can identify significant differences. Again, I don't want to extrapolate too much from these data, but it's to show the potential of these three approaches of statistical shape modeling. And the final thing to say, because we spoke about PPI and relevance, so what's also appealing, and it's also useful with what Maria was saying about NIHR, because it is a funding stream within a funding stream in a sense. But we've run a James Lind Alliance priority setting partnership on congenital heart disease, both for children and adults with congenital heart disease. And what it turns out from the process, which I don't have time to explain, but effectively it's a consensus-reaching process that identifies as the top 10 research priorities in a medical problem, is that both for children and adults, technology, including AI and including 3D modeling, are a research priority recognized by healthcare professionals, carers, and patients, hundreds of them that were involved in the process. And so this can really help strengthening the case when applying for funding, but more importantly, knowing that we're researching something that the stakeholders think it's useful. And so just to conclude on that, I think this intersects with some work that we want to do in terms of national strategy. Gosh.
Speak up.
No, it's fine. It's not. But the computer is still on, by the way, so I don't know what happened. So just to say, I'm the research lead for the local ODN, Operational Delivery Network within the NHS for congenital heart disease, so South Wales and South West. And so we're engaged in discussing the overall national research strategy, which is designed on these priorities. So that means that national collaborative studies will potentially also look at technology, 3D modeling, and AI, and this could intersect a lot with what Maria was saying around thinking around funding, especially collaborative funding, even beyond Bristol. I'll stop here. Thank you.